record.
So can
because
you,
we're gonna have a backup recording.
okay.
The room's recording also, and then do the
Sure.
display. And I'll hide that. We'll move it down here. All right, and then yeah. So I think if you can we see everything, and you can. Carolyn, do you want to try talking back?
Okay, great. So can you see my screen? It looks like you can. I'm gonna blow this up to slide presentation mode. So I'm wondering who's in the room. Now maybe we can do some introductions before we dive in to what I'll present today. My name is Peter Hunt. I am an associate professor in the Division of Experimental Medicine at the San Francisco General, I do a number of things. I do what we call translational research, focused on the role of inflammation or overactivity of the immune system and its impact on age-related complications in the modern treatment era. And then I also do a lot of collaborative work on HIV reservoirs and the HIV cure agenda. And so what I thought I would do today was touch on a few stories that I think are important in the inflammation agenda, and then I can talk about some of the collaborative work going on in HIV cure. I'm also a physician at San Francisco General Hospital, so I see patients a half day a week, and I would love to hear from you guys who's in the room and your background, and I'd love for you also to interrupt. I want this to be a conversation. Interrupt if you have questions, but maybe we can go around the room and introduce ourselves. I don't know if the audio, I guess the audio may not work, I guess. Yeah. Okay. So if you guys have questions, if you want to raise your, Lauren, how do you think we should do this? Because I think the audio in the rest of the room is not going to work.
It's not attached to my phone. I dialed in. Oh, the ceiling mics are off. Oh, Peter, I just turned the ceiling mics on.
Oh, okay.
Can you hear now?
Oh, yes, yes, I can. Yeah, that's
okay.
great.
Okay. We're in.
Technology.
All right, good. Maybe.
Okay, so I'll start again. I am Lauren Jones. I am both the chair of the Regular State Center for AIDS Prevention Studies, CAB, and I'm also a consumer that's been HIV positive for about 34 years.
Yeah, hi Lauren. We've met before through the AMPAR.
Yeah, we have. So,
all right, I'm Lauren Sterling. I manage the CFAR and have been at UCSF for 3 years. I don't know, you know me, so.
Jeffrey Brooks, community activist everywhere.
Hi, Jeff.
Hey, Peter, this is Cesar from CFAR.
Hi, how are you?
I'm Melania Kolash from the East Bay, and I've been positive 13 years. And
welcome.
So many
nice to meet you.
Nice to meet you too.
Ramon Ramirez, I'm a clinical health educator with Kaiser Permanente and been with the CAP for hundreds of years, and been working in the Latino community, trans community, and HIV adherence for several years already here in Los Angeles.
That's great. That's great. Welcome.
Thank you.
So I'm Barbara Green of JUCO. Apologies for not sending you an invite. Anyway, so my title here is the Research Partnerships Manager with the CAPS and the PRC.
Yeah. Welcome. Thank you. And thank you for having me.
Hi, Peter. I'm Darryl Mangosing. I'm the Research Communications Specialist for the Division of Prevention Science, CAPS/PRC.
Great. Welcome.
Hi, I'm Beth Bordeaux. I am the Program Manager for the PRC, and I'm still kind of new here.
Okay.
Aloha, I'm Carolyn Kuali'i, and I'm a CAP member, a prior HIV case manager through a Native Spin project, served as a capacity building specialist through CDC, and currently a CPG member on the California Office of AIDS, and been kind of involved in the work for about 30 years.
And I'm Greg Repchuk, and I'm an associate professor in the Division of Prevention Sciences at both CAPS and the Prevention Research Center, and I direct the Community Engagement Core, both for CAPS and the PRC.
Great. Good. Thank you.
That's everyone.
All right, great. So what I'd like to do, thanks again for having me, and I'm sorry for the mix-up on my calendar and that I'm not there in person, but I hope we can still have a really great interactive discussion here through Zoom. And I'd like to share one key story with you related to the inflammation agenda, and where I think we can start to develop new therapies to help improve and decrease age-associated complications in people living with HIV. So and then toward the end, we can get to a discussion on the recent updates in the HIV cure agenda as well. And I'm happy to answer any of your questions there as well. So to put this into perspective, we've made a lot of progress in the modern treatment era for HIV. This graph shows us the average life expectancy of people living with HIV. This is your average 20-year-old diagnosed with HIV. The red dots show the expected life expectancy. So it's now up to about 53 years in the last decade, which means people are likely to live into their 70s who are diagnosed with HIV now, and approaching what we see in the general population. But there's still a bit of a gap of about 12 years. So not restoring life expectancy to the general population, and this gap narrows quite a bit if we can identify people living with HIV at the very earliest stages of the infection and get them on treatment right away with a high CD4 count at the time they start therapy, or the so-called CD4 nadir. We can reduce that gap down to about 6 years. And the gap is similarly narrow if you don't include people who smoke, or people who drink alcohol, or people who have viral hepatitis. But a lot of these things are very common in people living with HIV and don't reflect the total population. Including the time when people start HIV therapy. Most of the long-term survivors on treatment for HIV now, they've been living with HIV for many years, and they started HIV therapy often at advanced disease stages. And we know that the life expectancy can be actually quite shorter in people who start late at a low CD4 count in green compared to people who start at a high CD4 count in orange. And that's relevant not just here in San Francisco and across the Bay in Oakland. This is true all around the world. There's now 20 million people on HIV medications around the world, and the vast majority of them have started at a low CD4 count. And the other nearly 20 million people who have HIV or are not yet on treatment, now, most of them also are likely to be starting at a low CD4 count, even though we're making every effort we can to get people tested and in care very quickly to start therapy. And what's more, there's lots of diseases that we normally associate with the aging process that are increased in people living with HIV. So heart disease or cardiovascular disease, heart attacks and strokes, for example, non-AIDS types of cancers are also increased, as are weak bones or osteoporosis and bone fractures. Those are all increased in people living with HIV, as is lung disease or COPD, kidney disease, liver disease, memory problems, so-called cognitive decline or pre-dementia. Sometimes we see it in people living with HIV, even at younger ages. And many of the diseases that I've listed here, including frailty, a syndrome of what we call multimorbidity, or lots of accumulation of multiple diseases that leads to difficulty with day-to-day functioning, can be increased in people living with HIV, particularly if they started treatment late in the course of disease. And so why is this happening? Well, many of these diseases are related to what we call lifestyle factors, smoking cigarettes or drinking alcohol, injection drugs. All of these factors are more common in people living with HIV than in the general population, and they all contribute to a lot of the diseases I've talked about. In the older days, the drugs we used to treat HIV, and many of you remember this from probably some of the first regimens you may have gone on, had a lot more side effects and were more difficult to take multiple times a day, food restrictions, lots of side effects, drug interactions, and many of those side effects may have led to some of the age-related complications that I talked about. But a lot of us have focused on the role of the immune system or inflammation in contributing to a lot of these disease risks. And so what is inflammation? So inflammation is the response of your immune system to any invading infections like a virus or a bacteria. Your immune system is an army of soldiers that helps prevent those infections from invading the body. And inflammation can also be a response to damage, to damage in the body. And so if you take a hammer and you were to bang your thumb by accident, what happens? Your thumb gets red and swollen. Those are symptoms of inflammation. That's actually your immune system responding to the damage in your thumb from the hammer. But inflammation can also happen at a much lower level all the way throughout the body in chronic infections like HIV. Where there's ongoing stimulation of the immune system at low levels, and it can take its toll on the body over time in all the different tissues where we see increased risk of diseases, like on the slide I just showed you. And so why do we think that inflammation is causing a problem in HIV? Well, we get an important clue from nature. And so the HIV virus actually came from another very related virus called the simian immunodeficiency virus, or SIV. That virus was, we think, circulating in monkeys that live in West Africa for thousands and thousands of years before that virus jumped into people in the 20th century. And one of the monkeys that virus could infect readily is this monkey here called the Pseudomangabe monkey. In fact, the virus that infects this monkey here did later jump into people, and that became the HIV-2 epidemic that you might have heard of. Primarily found in people living in West Africa or who have come from West Africa. But this monkey, when it gets infected with SIV, it experiences really high levels of replication of the virus in the bloodstream, just as high, if not higher, than we see in people living with HIV in the absence of therapy. But for some reason, this monkey doesn't get sick from all that virus replication. It maintains its CD4 counts in the blood, and it remains it continues to have a healthy immune system. But you take the same virus and put it in a different monkey. On the right, this is the rhesus macaque. This is a different species of monkey that doesn't normally get infected with the virus in the wild, but when it gets infected, it has very similar levels of HIV replication in the body, but it experiences rapid loss of CD4 counts, rapid progression to AIDS. And this is one of the animal models of HIV, actually. Now, the difference between the two monkeys, it's not the virus. The virus is exactly the same, and it replicates at comparable levels in the blood. But the difference is the response of the immune system in the body to the virus that determines whether the monkeys get sick or not. So the monkey on the left that doesn't get sick has very minimal levels of overactivity or immune activation of the immune system or immune activation. Whereas monkeys on the right that do get sick have massive levels of immune activation. And so this is all arms of the immune system. There's T cells and B cells in the body. These types of cells are supposed to respond to specific types of infections in the body, respond to HIV and help suppress it. But even the cells that aren't specific for SIV or HIV get activated. And the more that you have, the more rapidly you progress. And the same is true in people living with HIV. More overactivity there is of the immune system, the more inflammation, the more rapidly the disease progresses in the absence of therapy. So I'm going to stop there and see if there are any questions at that first part before I move on.
Yeah, a couple questions.
Yeah. Go ahead.
Ask a question.
This is Jesse Brooks, and this is really interesting, so thank you for being here.
Yeah.
My question was, well, I guess more so that you confirmed things that I needed to know, that I heard over and over, but you said it, was the inflammation that is caused in the immune system that contributes to these comorbidities later in life, but also you said something about the medication, the early medication contributing to those comorbidities. So what I'm asking now is, what about the new medications? Are they still toxic? Are they still contributing to these comorbidities? And I say this because I'm diabetic now, and it's in my genetics, but I also believe that the medications push me into diabetes at an earlier age.
Yeah,
So that's fine.
that's a really great question, and it turns out that diabetes is one of the most common diseases that people living with HIV now in the modern treatment era can get, and there is a lot of interest in trying to understand why that is. In the old days, a lot of the older drugs, some of the protease inhibitors like Indinavir, they could directly cause diabetes. Diabetes happens when your body becomes resistant to a lot of the insulin that your pancreas makes, and so your blood sugar levels go way high, and it turned out that some of these protease inhibitors like Indinavir could actually cause that resistance to insulin in the body and contribute to diabetes. And a lot of the older drugs, we think, like D4T and AZT, might also have contributed to the risk of type 2 diabetes and other problems of metabolism in the body, like something that goes along with diabetes often, fatty liver disease you might have heard of. That's also very common in people living with HIV, and also linked to some of those older drugs that aren't really in use anymore. The modern drugs that people tend to take now tend to be associated with much less of a risk of diabetes. At least they don't directly contribute. But something that happens with all HIV medicines, particularly in people who start HIV medicines later in the course of the infection, is that you tend to gain weight. And some people gain a lot of weight during early HIV therapy. And as you gain weight and more fat in the body, you become more resistant to insulin, and that can increase the risk of diabetes just by gaining weight. But we think that weight gain that people get during very early HIV therapy, it's usually in the first year of therapy, and we think of that as more of a return to health phenomenon, that HIV was actually causing wasting of fat in the absence of treatment. And if you didn't have the HIV, you may have had more fat. And so the treating the HIV actually causes a weight gain or a return to the state that you would have had before HIV. So we think that may be going on, but it is definitely true that in more recent years that we're seeing more obesity in people living with HIV, more weight gain, which can be contributing to type 2 diabetes risk. But my own sense is that it's not a direct cause of the drugs, but rather just the return to health and weight gain that comes along with HIV therapy. Go ahead.
Well, I was just going to say that's not a factor for me about weight gain, so that's why it was surprising when I became diabetic. And I also seen other people that don't have the weight gain factor that are diabetic.
Yeah, and that leads me to the final thing, which is actually this talk, this role of inflammation and overactivation of the immune system. I actually think that that's a major contributor to type 2 diabetes risk, or adult onset diabetes. We think that there's inflammation, as I mentioned, throughout the body, including in the fat tissue. There are a lot of these immune cells, part of the immune system, that army of T cells, for example, that I spoke of, that helps defend against infections. Those T cells, in the context of HIV, even during treatment, they go into the fat tissue and they cause inflammation there. And when that happens, it can increase insulin resistance. You can get scarring of the fat tissue, and the fat cells don't do the job that they're supposed to do. And you may not get expansion of fat, and at the same time you may increase resistance to insulin. And a lot of that, I think, may have to do with inflammation that's occurring in the fat. And so if you look at people living with HIV at any given weight, whether you're thin or whether you have a few more pounds like me, at any given weight, people living with HIV have a higher risk of diabetes. And I think it may be related to this inflammatory state.
One quick thing about that. Does the inflammation cause your organs to age? So, like, are my organs older than I am because of the inflammation and living with HIV over 25 years?
Yeah, so that's a really good question, and I think the risk of lots of age-related complications like diabetes, like heart disease, like some cancers, does seem to be increased even at younger ages in people living with HIV. Now, that's not to say that you're at high risk of getting a heart attack or a stroke tomorrow or something like that. That's just to say that the HIV is increasing this risk somewhat, and it's all the more important to focus on a healthy lifestyle, eating a good diet, for example, quitting smoking, all the more important if you have HIV. And so, and as the research community, people like myself are developing new therapies to treat this inflammation that's there. There are all these other things that you can do to improve your health and decrease your risk of disease. So we always we don't want people to think that there's nothing I can do. My organs have aged. There's really a lot that you can do through diet and exercise, quitting smoking, that sort of thing. That can really help.
Thank you.
Yeah, sure. Yeah, Lauren.
Yeah, I wanted to ask, is there a way to predict like who you're going to be if you're more of a Sudi than a Rhesus? I just asked that because, like I've been positive like somewhere close to the 35 years now, and I actually didn't take medication for a long time of it, for almost 20 years. And is there a way to know who you are? Because I didn't, I wasn't inclined to take medication for a long time because I was relatively healthy. And then I had kind of my dive bomb period, when my CD4s went down to, somewhere close to 250. But then when I did take the medication, they came right back up to about 1100. But much to my disappointment, within the last year, I had to switch all the medications because all of a sudden my kidneys started to shut down, which kind of surprised everybody because I went from taking one pill to taking, like 3 to 4. And then the issue of being older, because I'm like 66 years old now, being older, then all of a sudden there was all this other stuff, piled onto it. And now, I'm not really quite sure, what to do because I'm not any more inclined to take a bunch of pills than I ever was. And, it's just a very odd thing because you don't know what to associate with what. like what's like normal aging and what are things that are related to the HIV, you know, like memory problems and that kind of thing. So is there a good predictor of who you will be?
Yeah. So I'm gonna jump on that note. I'm gonna jump to this slide here, and this is a study where they a research study where they followed people who are on HIV medications on a stable regimen for up to 10 years. That's 10 years down here on the bottom axis here. And then they looked at the percentage of people that experienced one of these diseases like I'm talking about, a heart attack or a stroke, a cancer, a fracture, osteoporosis fracture. They measured, and again, this is thousands of people, these markers of inflammation in the bloodstream. And these markers of inflammation, when they were high, that's in the red, the very highest group of people in these markers, they had over a 20% chance of having one of these diseases after 10 years. But in people who had the lower levels, the bottom half of the group had only about a 5% chance. So there was so these markers of inflammation can really help predict things. Now, the problem is they're not really good for use in the clinic just yet, because in a research study with thousands of people, these markers of inflammation from the blood test can help predict who's at higher risk or not. But for an individual person, they don't really predict all that well, in part because these lab tests tend to fluctuate a lot in the bloodstream. So you could be high in the morning, and then you could have a lower level in the afternoon. And because it's fluctuating so much, it's hard to really tell. There are other clinical tests that people are starting to use that you may be getting already in the doctor's office. If you get your CD4 count checked, sometimes the CD8 count, another type of T cell, is also checked. And it's the so-called CD4 to CD8 ratio that is often checked. And when that's low, that can be associated with an increased risk of disease. But these are just these are still, I would say, research level tests, and I think the field is working now towards developing better tests so that we can predict with more confidence who's at higher risk for disease and maybe needs a new therapy to help prevent them from getting sick in the future, versus people who have really low levels of inflammation that probably don't really need a new therapy. And as you point out, Lauren, that there's so many, as you get older and you accumulate, you have maybe a kidney problem, or you have high blood pressure, or you have diabetes. You end up needing to take all these other medicines for those things. You accumulate all these extra pills, and that can be really hard to manage. It's easier to forget your medicines if you're taking so many. There may be interactions between the medicines too, and so we really want to keep things simple as people are getting older with HIV. And so we don't want to give people a new medicine if they don't really need it. For example,
the other thing that I think is interesting is looking at life stress. Beyond whether you smoke or drink or whatever. Like even if you're living kind of a puritanical life, but if your life has a lot of just life pressures on it, like paying your bills or dealing with your partner, so that kind of thing. Like how much does that actually influence your longevity, whether you're taking the medications or not?
Yeah, that's a really good question. So we often think about stress impacting your mood and depression, or your ability to stay on the medicines regularly. But and if you have a really stressful life, it's hard to do those things. Or harder to do those things. But there are also other direct ways by which stress can actually impact the function of the immune system directly. And there are many different ways that did you know that there are actually nerves that come down from the brain, and the nerves go into the lymph nodes where immune responses develop. When you're stressed or when you're depressed, it may have a direct effect on how the immune system functions through a lot of these mechanisms. And cortisol is a hormone that your body makes when you're under a lot of stress. And that also can suppress immune function. And so there are lots of not just you're right. You're exactly right. It's not just about eating a healthy diet and not smoking, but also minimizing stress in your life, or developing strategies to cope with stress that can probably really have a helpful effect on the immune system too, and decrease your risk of disease beyond just simply whether you remember to take your medicines or not. So I think that's a really important point.
And I'm going to jump in here real quick, just because it looks like, according to my time, it's 2:55.
Yeah. So Barbara was saying we can have until 3. We need to hard stop at 3:15 to get upstairs.
Right. I
Okay.
passed it around. I guess it didn't get to you, Lauren.
Oh, I'm supposed to.
And we have 2 questions. Alania has a question, and then
Yeah.
Carolyn has a question.
Oh yeah, sure.
So 3:15, you guys.
Sure.
Okay, so based on the information you said about what is it, Scooty or Sooty monkey?
Yeah, the
So you
Sooty
said
monkey. That's
SIV
right.
was around a long time and somehow, mutated to be humans to HIV. So what I'm thinking is maybe back whenever SIV did come up, these tribes or the indigenous population had no way to get to water, or had, different ways of hunting methods. Is it possible that the SIV was, mutated to humans by either drinking the blood of the monkey, or while they were carving it up or something like that? Like they cut themselves and it was transferred. Like, is it the same? You know what I mean? Because they said we're so closely related to monkeys. Is it very possible that that's how the mutation began?
No, that's a very insightful question, and in fact, that's exactly what we think happened. So the scientific community has actually developed ways to by looking at the genetic composition of the HIV virus and comparing it to the genetic composition of the viruses in various monkeys in West Africa, and has not only been able to identify exactly which monkeys, from which monkeys the transfer into people occurred, and the HIV-1 epidemic, or what most people around the world with HIV have, it came from at least 2 different transmission events from chimpanzees that were infected with SIV into people. And the first events happened, we think, in the late 1920s, early 1930s, actually. So we think of the HIV epidemic as being something that's probably started in the 1970s or 1980s in the United States. But if you look in Central and Western Africa, there was evidence of HIV in those populations, during even from the 1950s. There's evidence that people were infected, and we know based on the genetic similarity of the viruses when it probably came into humans, and it probably was in the late 20s, 30s, and probably in the monkey poaching industry, where there probably was exchange of blood during the hunting of monkeys.
That makes a lot of sense.
Yeah, and so that's you're exactly right.
That it could have been around longer than we know, because all over the globe there are indigenous peoples, and they had to survive any way they can. Now, it's very possible that it's been around way longer, mutated way longer, and people just were unaware and just thinking, okay, hey, this person died, and whatever they had, they gave it to this person, so we're gonna have to just kill everybody type thing, like they do mad cow disease. So I'm like, is it possible that the immunovirus has been around for way longer, like hundreds of years, rather than just, this span?
Yeah, I don't think that's possible in people, based on these genetic studies that have been done. If that happened, we would have seen some changes in the virus as it sort of adapted to replicate better in people. We would have seen those changes occurring, much earlier. But we really do think that the first transmission events were in the early 20th century. But that's still a lot earlier than most people in the world think of, right? Most people think that the HIV epidemic probably started in the 1970s or 1980s. But really the first transmission events were in West and Central Africa in the late 1920s, early 30s, and then through along truck driver routes in between major cities, and in particular Kinshasa, Congo, is where a lot of we think a lot of the early human transmission happened. The virus became able to replicate better and transmit sexually, and that's how the virus later spread eventually throughout the globe.
And Carolyn's question? So staying on the monkey, so have you guys determined why one monkey is resistant and the others aren't?
Yeah, that's a really great question, and it's still a little bit unclear. We know that the monkey that doesn't get sick kind of ignores the virus. It doesn't have its immune system does not get activated, and it doesn't get inflamed. And it's still a little bit unclear exactly why that is. We have some. Go ahead.
I'm wondering if environment has anything to do with it. I'm thinking. All the way back in the early 90s, people were talking about inflammation and HIV, especially in gut health. Yeah. Because a lot of people living with HIV had a lot of problems with their gut, and how that was really unhealthy for them, for when it comes to staying healthy. And so, I'm just wondering, because I work in Native communities tend to use traditional healers. Yeah. And I've been hearing this among traditional healers, and even in Native clinics, which are biomedical clinics that have traditional healers working within the clinic system. These are some of the things that they have always addressed is issues of inflammation, not just in HIV, but in all types of diseases. And that seems to be a traditional kind of philosophy when it comes to looking at health and well-being. And so I'm just wondering how much in the biomedical field has there been any research to look at the integration of more, what I guess people would relate to as complementary medicine, and and back to the whole thing of stress, I know that within the Native community, one of the ways of dealing with it is through ceremony, and more spiritual kinds of things. And I can, attest to when I was an HIV case manager working with Native community people living with HIV, that was our main, that's the program that we ran. We had traditional healers involved. We worked on that was our route of, my clients were also on meds, but it was an integration and it was a holistic approach. And I'm just wondering, because I don't hear too much research around a more holistic approach to wellness in the HIV arena. So I'm just wondering if you could speak to that.
And along with that, I'm just wondering, because it sounds a little bit to me like there's, for some people, and I guess I was one of them, some of the attitude is, if you have so many other factors in your life that you're dealing with, maybe, not making HIV the highest priority in your life, does that work better for, has anybody even studied whether that works better for some people than to actually intensely, constantly be focusing on your HIV as the center point of your life?
Yeah, so let me address those. Are all really great questions. So let me address a couple of things. One, I think understanding the local community. So if we want to help people to live healthier lives, part of that is really understanding the local community. And there may well, and as you pointed out in the beginning of your question, if sometimes that means really integrating what based on science is really likely to help improve the health of someone, prevent them from getting advanced AIDS and dying. We know that the medications to treat HIV are profoundly effective. But at the same time, it's helpful to integrate that with an understanding that people have in the local community, and to marry that with local traditions and customs, rather than make these completely two separate things. And that was a great tragedy in South Africa, for example, where the focus on traditional healers was at the exclusion of acknowledging that HIV causes AIDS, and many people died because there wasn't that marriage of the two, the effective therapies that can really improve health, without really trying to accept the local context and really trying to help people understand how this can work alongside traditional methods. And I think that we need to meet people where they're at and really understand them, to develop a dialogue and help.
If I can just say something about that, and I agree with you. The challenge is that being able to evaluate that and showing success. That when I did capacity building and I worked with Native CBOs, it was really hard for them to evaluate their programs based on traditional practices compared to more quantitative results instead of qualitative results. So, I think this is where researchers can really be helpful and begin to do more research around this so that we can get the hard information that funders need to see so that they can say, well, this is worth funding. Because the communities that are doing this, they're not funded to do these kinds of work. Yeah.
Well, I think that a lot of the biomedical research now, even we haven't talked really much at all about cure, but a lot of the similar concepts come to play there too. You're asking me to take this fancy new experimental therapy to cure HIV. And this is maybe not the top priority in my life right now. And pairing the biomedical research with really qualitative research, understanding from someone who's participating in research what their experience is like, or someone who decides not to participate in research, why they elected not to participate in research, and trying to understand that so we can more effectively meet people where they're at, and help them more effectively. I think all that's critically important. A lot of that is happening in the HIV cure space. Qualitative researchers really trying to understand whether people are interested in participating in research, and if not, why. And those that do participate in research, what their concerns and fears are, and they often have very different perspectives than the HIV doctors and the researchers that are trying to help. Lauren had also mentioned another issue. Sometimes this is HIV is not your top priority, right? And here we are talking about additional therapies, either to cure HIV or to reduce inflammation and decrease risk. I think we are entering a new era where there are more treatment options to help people with HIV, injectable therapies, so you don't have to take pills every day, but you may just need an injection once every couple of months. And new models of care that are being piloted at San Francisco General for people who don't normally come in to see the doctor because oftentimes there's mental illness issues, there's substance use issues that make it difficult for people to make it to regular appointments on time. Yet they often have ongoing medical issues that they may come into the emergency room or urgent care. And so we're modeling new ways of delivering care, meeting people where they're at. If they're only coming to the doctor when they have those medical issues come up, well, let's try and deal with the HIV there when they're coming into the clinic, and not just waiting for them to show up to a regular scheduled visit. So I think there's so much that's happening in the HIV world right now, focused around trying to meet people where they're at, trying to understand how best to design interventions to improve the health of people living with HIV. So they're really addressing the needs of people living with HIV, and so I think all that's really important.
Can I ask a quick question?
Sure.
So jumping to where you were talking about stress and inflammation, right? So my mother has a saying that we got from my great grandmother: if you are stressed out, you're gonna die, right? Period. So my cousin, right? Let's just use her as an example. She has, type 4 brain cancer, and she was completely stressed out. The medication was completely just inflaming her. It was bad. And then, she decided, okay, I'm gonna have to cut back traditional and go holistic. And I want to say within 6 months doing both therapies and the holistic treatment, it helped to calm her, to lift some of the stress, and then the medication portion of it, she got really healthy out of nowhere. So is it possible that when we're talking about a cure, inflammation and stress, that all three are tied together? I mean, of course, I have my own thoughts of cure, but is it very possible that our stress is the cause of the inflammation from the HIV medication? And is it very possible that if there was a way to, like you said, marry the holistic and marry the traditional Western methods, that people will live longer and be more healthier and more inclined to take their medications? Because right now, I think about I want to say 26 pills. I take my medicine 3 times a day. And if I didn't have to take all that medicine, okay, if I ain't need it, I would not take the medicine because I am not a pill person. And I don't stress much. And as a result, my CD4 count stays over 2,400 always. And in great levels of stress, I'm just down like a dog, and pneumonia kicks in, and then my kidneys start hurting. And then right now, today I'm stressed out, so I notice my skin is, agitated. So is it possible that it's all closely related when we come to talking about a cure to marrying the qualities?
Yeah, I think
those words. We have about 2 minutes left.
Okay. Right. So yeah, I totally agree that stress can play a role in increasing your risk of disease and even weakening the immune system. I don't think it's the cause. It's not the primary cause of how HIV causes damage to the body, but it certainly can make things worse. And stress gets in the way of all aspects of both being able to take medicine to treat the HIV, let alone the function of your immune system. And so I think that holistic approach is always important. Any therapy to treat HIV really has to be paired with making sure your overall wellness is that we're addressing your overall wellness.
And we want to thank you so much for your presentation. Unfortunately, we do have kind of a long agenda today on a regular meeting, so we will thank you so much. And people, I'm sure, can get back to you with more questions if they have any. Thank you.
Sure, of course.
Thank you very much for the information.
All right.
Thank you.
Take care.
Okay, we need to be upstairs like now. And so if you all can do your part in cleaning up this room, which I'm sure we're responsible